Thanks everybody for coming along this evening, and it was great to have an opportunity to talk to some of you at the beginning, and hopefully there'll be more opportunities afterwards for you to talk to us or any of us, and I'll introduce who us is in a moment. So my name's Professor Graham Hall, and I'm one of the researchers here at the Telethon Kids Institute. And some of you may be aware that we used to be the Telethon Institute for Child Health Research, and we changed our name recently really to reflect what we hoped is what we're trying to do, which is to do research that the community and the stakeholders that we work with find important. And an important part of an aspect of that is that we communicate back to you what we've been doing. So what have we found with our research? Many of you who have helped us with that research. And so this is a way of us being able to, I guess, have a discussion with you about what we've found and what we think that might mean, but also for you to have a discussion with us about maybe what you'd like us to be doing in the future or questions that you have. I'd like to acknowledge that we're on Noongar land and acknowledge elders past and present. Okay, so what we're going to do tonight is really give you a tour of the research that we're doing, but in a sort of a growing kind of way. So initially we're going to have Professor Jane Pillow, who some of you may know is a neonatologist consultant down at King Edward Memorial Hospital, but also a researcher of international repute. And she's going to be talking to you about really what's new in the neonatal intensive care unit. So if your baby has been born preterm and needs a little bit of extra help breathing, where we've come from and where we're going towards. Then Dr. Adelaide Withers, who's one of the respiratory consultants at Princess Margaret across the road, is going to talk about some of the research that we've been doing with safety for air travel. So, and how we've been working on that for the past almost 10 years now. And then I'm going to come back at the end and talk about what we've been doing in school-aged children. So, you know, once Jane's finished with them and Adelaide's finished with the children, they're grown up and they're at school, and really looking at what are their lungs like then when they're 9 or 10 or 11. And does that tell us anything about what they were like when they were babies? And can we tell Jane and her colleagues what we're finding that maybe makes it that they can refine how they treat, use all of these very much life-saving treatments, but use them in a way that maximises the benefits and minimises the downsides. And then at the end we're going to have a panel up here. You can ask us lots of questions, and for that we've co-opted also in Dr. Andrew Wilson, who's one of the respiratory consultants across the road at PMH as well, who's also been heavily involved in a lot of our research. So before I hand over to Jane, I guess I just wanted to give you an overview of preterm birth. And what it's like in Australia and West Australia at the moment, and how it can impact on the lungs. So this is the latest data from 2011, and this is collated nationally from the midwives and all of the neonatal units. And so there were about 8.3% of births in Australia that were preterm. And when we say preterm, we mean less than 37 completed weeks. So that would be 37 weeks and 6 days. After that, they're 38, and they're not considered preterm anymore. That means about 23,000 babies were born in that year preterm. So to give you an idea, because the number's not very meaningful, that's almost the capacity of the WACA on a good test match, maybe Australia and South Africa, but Ashes would be much higher. In Western Australia, that's just over 2,500 babies that were born preterm. Unfortunately, the prevalence of preterm birth is higher in Aboriginal mothers, so it's about 14%. But the number of children being born preterm is increasing slowly over time, not only in Western Australia and Australia, but also in Western society. Traditionally, we think that babies that are born less than around 32 weeks tend to have poorer outcomes when it comes to lung health. And this is a sliding scale, so this is that looks like a line in the sand, that if you're more than 32 weeks, everything's great, and if you're less than 32 weeks, it's not great. Of course, that's not true. Every baby's different, as you know. One of the things that we talk about a lot is neonatal lung disease of prematurity, or bronchopulmonary dysplasia, or BPD. And this remains the most common chronic lung condition in infants. One of the things, because Jane and her colleagues are exceptionally good at what they do, is that with the advances in neonatal intensive care unit, we're seeing dramatically increased survival of babies at much lower gestations. So the type of babies that now graduate out of the neonatal intensive care unit, we wouldn't have seen 15, 20 years ago. And so the face of these preterm children has changed a lot, even in my research lifetime, let alone my lifetime. And one of the things that we're really trying to do is get a good handle on what lung problems there may be, if there are any at all, which factors seem to be most associated with those lung problems, so that we can then feed back to Jane and Andrew and our other clinical colleagues and say, well, this is what we're finding, and are there ways that we can do what we're doing better to minimise the harm and maximise the benefit. So what are we talking about? So this looks a bit gross, but this is from a colleague in Bern, Switzerland, and this is really a cast of the airways in your lungs. So if you were silly enough to swallow a large bucket of plaster of Paris, and then were to remove your lungs, apart from being a little bit uncomfortable, this is what it would look like. So you have the trachea, which is obviously going up to your mouth, and then that branches into two. Yes, I know. And it branches into two again, and it keeps branching and branching and branching, so that when you get down to here, you're looking at very, very small airways. And obviously this is from an adult, so in obviously infants it's very much smaller. But really, the interesting bit is the bit that's not in this picture. In terms of preterm babies, and the interesting bit is the lung tissues. So this is where the oxygen comes, when you're breathing in oxygen, it goes down the airways and it crosses into the lung tissues, so this bit here, and the oxygen goes into the blood and the carbon dioxide goes out. And if you move in even closer, you get this pattern. And so really what we're talking about is this very complex, incredibly well-designed lung tissues where we get the gas exchange, so oxygen and carbon dioxide moving backwards and forwards. And it's this area of the lung that seems to be most influenced by being born early. And so what does that mean? So this model was proposed in the 60s, late 60s, early 70s, and really this is just saying that if everything's normal, as you grow, your lung function gets better, and then you get to your own personal peak, and then sadly for lung function, you start to decline at about 35. So it's not 40 and you're over the hill; it's 35, and then it slowly goes down. If you were silly enough to smoke, it will go down faster. So I hope no one here smokes. You should stop immediately if you do. If for some reason you start with something in early life that means that you don't travel on this highway, if you like, then you may not achieve the same maximum that you would have otherwise. And so that also then has the problems that if you also then take up smoking, your lungs can change even faster than before. And so what we really have been looking at is what can we find here that will help us understand where these preterm babies are on this trajectory, because if we can find out what's going on here, we can push them from this slope to this slope. Because once they're here, once they're adults, really that is what they are. They've reached their maximum and that's where they'll be. And it may not mean that there's any real problems, but if we can move everybody a little bit higher, then not only do we set them up for a much better childhood, but we set them up for much better adulthood and for the rest of their life. And so really what we're hoping is that by small incremental changes earlier, we can lead to big changes over the whole course of their life. So what type of factors affect how the lungs grow in preterm babies? So there's lots. It's genetic, developmental, nutrition, and then after they're born, there's, do they get an infection in the intensive care unit? Some of the treatments that are life-saving also have downsides, and Jane will touch on those a little bit more. And so all of these come in together. And so when we're looking at these factors, it becomes incredibly complex because we can't just say it's this one thing, because they all mesh in together. They don't just operate by themselves. It's like a bowl of spaghetti. Everything's linked into something else, and it's hard to pick out that one strand that really makes a difference. And so what we've been trying to focus on is to get as much of that spaghetti as we can. So where are we? So this is really how the lungs develop over the whole of a normal pregnancy, such that at 38 weeks you have those alveolars, so those little lung tissue units that I showed you before. You have the surfactant growing, and the lungs are really doing what they're meant to do. In the late 80s, when children were born and they developed BPD, or this neonatal lung disease, they tended to be about 28 to 34 weeks. So they were what we would consider today to be quite big babies. But because Jane and others are very good at their job, what we're seeing now is that babies that are 22, 23 weeks are graduating out of their neonatal intensive care units. And so at that point, where the lungs are at in terms of their normal development is much earlier. And so now, instead of the lungs developing in the womb like they do normally, they're developing in room air, which is a little bit different. They're being exposed to medicines and other things, and all of those things subtly change how the lungs then develop and grow. And so really what we're trying to do is tease out those subtleties. So what are we doing? Well, as I just mentioned, the ex-preterm or the old BPDs, really, they're only now in their 40s, so it's not like they're that old, in inverted commas. But the new generation are only really now finishing university. And so when you think about that, that's a huge change over a very short period of time, and it's still changing. And so what we're really trying to do is really key down on this. What is the impact of these early life events, and how is that going to impact on ongoing health problems, or hopefully not ongoing health problems, because then we're able to give information back to our medical colleagues, which means that treatments can be improved, but also we're able to give more accurate information back to the families and say, well, this is what we see in general. These are the things that you might be able to expect with your baby or your child or your adolescent or your university student. And so that families can better plan and have an understanding of what the challenges might be ahead, and then so that they're forewarned and forearmed, as I was talking to someone earlier. So I'm now going to hand over to Jane Pillow, and she's going to tell us about what she's been doing in the neonatal intensive care unit.
Thanks, Graham, very much, and very happy to be here. So just move forward. Actually, wanted to change my title a little bit, because this is really what we're out and about, is trying to get better outcomes for babies who begin breathing too soon. And the obstetricians often joke with us and say that their goal in life is to make sure that neonatologists are out of a job by getting mums through to term. So my goal in life is to make sure that Graham and Andrew are out of a job by making sure that the baby's lungs are so good by the time they leave the unit, they're not going to need long-term care. We'll see if that works or not. But what I would like to tell you about are some of the changes that we have happened, and particularly some of the research that we've been involved with locally in the University of Western Australia that is improving the long-term outcome of these babies and really improving their lungs. So when we first see a baby, it's often like this, and some of you as parents will maybe have some memories. Maybe you missed out on seeing that first moment when your baby was delivered and put onto the resuscitator. And the first thing we do is very quickly warm them down or dry them off, and then put a mask on their face and help them to breathe. And at this point, the baby's heart rate may be going down. The neonatologist's heart rate is usually going up, and they're thinking one thing, and that is breathe, you're alive. So the goal then is to try and work out how much this baby can breathe for themselves and how much we actually need to support them. So surprisingly, quite a lot of our preterm babies actually come out and breathe very well, and that's because they've had very good antenatal care and often because they've had treatments before they've been born that helped them mature their lungs to some extent so that they're not having such difficulty when they're breathing as you might otherwise expect from having very, very premature lungs. Other babies do need a little bit of help, and many of you might recall having your baby on nasal CPAP or continuous positive airway pressure, where we just have some little prongs into the nose. There's a constant pressure being pushed in there, which helps to inflate the baby's lungs and stop it from collapsing. But the baby is doing all of its own breathing with just a little bit of pressure support. Other babies do have quite a lot more trouble breathing. Sometimes they don't know how to breathe at all. Other times they'll breathe, but their chest is really pulling in. They're struggling very hard to breathe, and they just can't get enough air in and out of their lungs in order to get the oxygen in and out of their airways and the carbon dioxide or the waste gas out of their blood. So Graham's already pointed out to you that we're looking at a much more immature structure when we have babies born very premature. And there's a huge amount of development that goes on in those last 13 weeks or so of pregnancy, or longer, 16 weeks. So this is actually just looking from 30 weeks to full term, but you can see that the lung volume more than triples just in that last 10 weeks. The surface area of the lung, and that's what's really important for getting the oxygen across and carbon dioxide coming out, more than increases about 4 times, and then the thickness of the gas exchange barrier reduces by about 2/3. So there's huge changes that occur during that time, and we're really dealing with babies with very underdeveloped lungs. So how can we help them to breathe without actually damaging their lungs in any way? And actually the most popular treatment at the moment goes way back to 1975, and this was first introduced in New York in Columbia Children's Hospital by Zhenten Wang, and it was called bubble CPAP. And it was introduced, and then it never went anywhere very fast because people got very interested in intubating babies and ventilating them to keep them alive. But over the last 10, 15 years, there's been a huge revival of interest in this non-invasive method of helping babies to breathe with those little prongs in through the nose. And it turns out that this bubble CPAP has got some very neat aspects of it that actually don't just provide pressure to the lung, but actually actively help the baby to recruit lung volume, air into their lungs so that they inflate better, and also make them more efficient with their gas exchange. So we've actually done quite a lot of work on bubble CPAP, and the work that we've done in Western Australia has really shed light, I think, on understanding how this treatment works and why it seems to be so much better than many of the other non-invasive treatments that are around. So one of the things that we saw is that the pressure waveform, instead of just delivering a constant pressure to the airway opening and just having a constant pressure distending the lung, that we actually have this wildly fluctuating pressure that's being delivered to the lung, or certainly to the airway opening. And then it damps down, but there's still a bit of oscillation in the lung. What's really interesting is that when you have a sick lung, you get higher oscillations coming through to the lung, and that actually actively helps the lung to recruit. And I'm going to show you how that might happen. So this involves a principle that we call stochastic resonance. So it's a little bit of physics here, but I'm going to try and make it simple. Essentially, what this involves is trying to take advantage of something that's a non-linear system, and the non-linear system is actually the lung. It doesn't behave, if you put something in, you get something out, and if you put twice that amount in, you get twice that amount out. It doesn't behave in that manner. So that's what we mean by non-linear. So if you have a non-linear system and then you have what we call a weak sub-threshold signal, so that might be just the immature breathing. They're breathing, but it's just not enough to really open up their lungs and inflate them properly. What we can do is just add a little bit of noise. And if you superimpose a little bit of noise on top of that, you can get them over the line. So if we now put a bit of noise, and that might be the bubbles in the CPAP system, effectively you can jump them over the line into the next well, or in the case of a lung, make them just open enough pressure that they suddenly inflate part of their lung and recruit their lung and get the air in and out more easily. So that's the idea about stochastic resonance. So this is how it works. This is a pressure volume curve of a collapsed lung. So what this says is we apply a lot of pressure before we start getting any movement into the lung, and then we get to a point, a critical point, where as we apply pressure, we suddenly start recruiting air into the lung until we suddenly overinflate it. And if we put some pressure into the lung here, then we'll get so much volume being recruited or so much air coming into the lung. If instead we put a variable pressure in, still keeping the same mean pressure overall, we can take advantage of the fact that this is non-linear by really taking advantage of this steep slope here, so that we get a whole bunch of air in when we just put a slightly higher pressure in, but when we put a lower pressure, we only lose a little bit of the volume that we had previously. And the net effect is that we get extra volume. So that's how bubble CPAP works. And we've been able to show that. And this is just another example of that, but just showing you that the lung actually, because of its branching structure that Graham told you about, opens in a series of avalanches. So if we can open critical threshold bits that are closed because they haven't got the right pressure, then suddenly we can get the whole lung open. So putting a pressure in of 25 would only inflate the blue bit here. But if I suddenly have that pressure going, say, 27 to 24 or 28 to 24, then I might open up the red bit. And if I have a little bit more amplitude, maybe I'll open up all this bit, leaving just a small amount not recruited. So that's just trying to get the concept to you of noise. So, just so you can hear what this sounds. So the lungs actually recruit, and what we can do is put a microphone down into the lungs and record these airway opening events. If you have a listen, you're going to hear that avalanche. Starts very slowly, and then it speeds up, builds up, and this is all the units opening up. And you see this avalanche occurring as all those lung units are opening up, and then these units are just as the units needing that higher pressure opening up, and then it tails off. Okay. So we looked at this in premature lambs, and what we could see is the carbon dioxide, that's the waste gas that we have, was lower in our lambs that were on bubble CPAP, which is that variable CPAP, compared to a constant pressure going into their lung. And they also developed better oxygen levels than their constant pressure counterparts. And that oxygen, higher oxygen, is because they're recruiting more air into their lungs. And this is from colleagues in Utah that have got preterm lambs that they ventilate for long periods of time. They're looking at a slight variation on that form of bubble CPAP, but effectively showing you that if they're on this high frequency oscillation kind of pressure over a long period of time, doing all their own breathing, they get these beautiful clear lungs and this nice well-developed lung structure. But if we keep a baby on a ventilator for a long time, the lung does develop, but not nearly so well. And the units that we have are big and open, and they're just not got the detailed structure or the surface area that we need for gas exchange. I'm sorry. So I want to move on now. We looked at bubble CPAP. One of the things that we're now looking, because when we give bubble CPAP, we can't give surfactant, and many babies get surfactant when they're born to help them breathe better. It's a detergent-like substance. We all have it in our lungs, and it stops our lungs from collapsing. Trouble is, if we don't put a tube down into the lungs, we can't give surfactant. So we're looking at ways that we can do that. So we've just finished a randomised trial of giving CPAP by nebulization into the babies. And this trial has just really achieved international acclaim just very recently. We're hoping it's going to be published very shortly. And what we've found is actually we reduced our overall incidence of intubation to 1/3 of the control group for the babies who got the surfactant. And this has got really widespread implications. This kind of treatment we could give worldwide, in areas that don't have intensive care units, areas where they don't have a paediatrician who can intubate a very tiny airway. It could reduce the severity of disease before we go out to collect that baby to bring it back to an intensive care unit. Or it may also mean for some of the slightly bigger babies that they can be treated in their home hospital, whether it's Kalbarri or Geraldton or wherever it might be, Esperance, whatever. But it may be that they don't have to be transported up to Perth and their mum doesn't have to be separated from their other children in the family. Okay, so the QNAB trial, that's just showing you the outcomes and the nebulised babies that had much reduced rate of intubation compared to the ones who were just left on normal CPAP. However, some of our babies really can't breathe on their own and we do need to intubate them. And then the secret is how can we ventilate them and damage their lungs as little as possible so that we can optimise their long-term outcome. And one of the big advances here over the last couple of decades, and an area that I've had quite a lot of experience with, is high-frequency ventilation. So this is a bit different because we breathe, and you and I breathe at about 12 times a minute. A normal baby breathes somewhere around 40 to 50 times a minute, maybe 60 times a minute. But high-frequency ventilation, we're actually breathing for these babies up to 900 times a minute, effectively just vibrating them. And in fact, one of the first ventilators using this modality was called the hummingbird. And it was taken because the hummingbirds actually create some ventilation through the flapping of their wings, and they do that at a very high frequency. So our normal ventilators breathe just with conventional pressure going in, like a normal breath, and coming out. And high-frequency oscillation instead puts this very high-frequency signal on top of that. The difference is that during conventional ventilation, this black line, almost all of that pressure and quite a lot of volume is transported all the way down into the alveolar area, or the distal part of the lung. And Graham's already shown you how undeveloped that is in the premature baby. With high-frequency ventilation, it's really damped. So the amount of pressure and the volumes that we get down to that very fragile part of the lung are markedly reduced. We've been looking at ways that we can improve that, because although this treatment theoretically is better and we can show in animals that it's much better than the conventional treatment, it's been difficult to demonstrate it clinically, and part of that is trying to teach clinicians how to use this modality properly. One of the things that was shown just recently, and this is a complex slide, but just showing you one of the things we do is recruit the lung by turning the pressure up to get air in and then bringing the pressure down as low as we can. But when we do that on high frequency, because we're opening the lung up, the ease with which that lung gets air in and out changes as we do that process. And suddenly we get volumes going up and then volumes down and then up again, and the carbon dioxide level goes down and then up and then down and up. And that can really change the blood pressure and the flow of blood through to the head and put the babies at risk of other serious neurological problems. So we're trying to find ways to make this happen a bit more safely to protect the babies from those problems. And one of the ways we can do that is actually, instead of limiting the pressure with each breath, is limiting the volume. I'm going to just skip that slide. It's a bit difficult to explain, but we're looking at ways to limit the volume with each breath so that we can work out what volume the baby needs and keep that volume constant, and then just let the ventilator vary the pressure, because pressure is probably less dangerous than volume. Okay, so the other thing that we've just recently started thinking about is high frequency. Should we be doing it with one frequency, or maybe we should be looking at multiple frequencies, because every part of the lung is a bit different and every part of the lung probably needs a different frequency to ventilate it the best way. So some work that we did last year has just shown that this is multi-frequency ventilation here, that we can ventilate the lung using lower mean pressures and also much more efficiently, so with lower volumes, by using a multiple frequency signal, and that is really going to change the way that we do that oscillation. Taking on that variable theme, and I've just kept one theme going through this presentation tonight, but we're also looking at conventional breathing and the normal breathing rate that we have on most of our ventilators, and whether instead of just delivering a constant rate and constant pressure ventilation that we have done for years and years and years in the unit, whether maybe getting babies to breathe a little bit more like you and I do, which is variably. We have a different tidal volume with each breath. Sometimes we speed up, sometimes we slow down. Sometimes we take a big sigh, and if I'm really boring, you'll be sighing a lot. But that's how babies breathe, and they do that quite a lot to recruit lung air into their lung. So we're trying to imitate that by putting variability back into their breathing waveform. And this is just, so we're calling this biologically variable ventilation, and just showing you the black line here is if you get this variable ventilation, this is the compliance of the lung, which is how easily it inflates. And if we give them variable ventilation, the lung ventilates or opens much more easily than if we just give the constant rate and constant rhythm ventilation. So those are some of the changes that we've been doing in our ventilation, or specifically in the neonatal practices. At the end of that, we need to be able to assess what's happening. Graham told you that they're doing studies here to look at the long-term outcome. We have a recent NH&MRC grant that I'm leading, and Graham is CIB on, which is looking at the long-term outcomes for our current generation of premature babies. So we've got about 500 babies being recruited into what we're calling the PIFCO cohort, the preterm infant functional and clinical outcomes study. But it's really looking at multiple effects, not just the lung, but also the muscles that we use for breathing, and the heart, and how that all interacts to what we think is a very complex disease, and that's bronchopulmonary dysplasia, chronic lung disease. Have I got 2 more minutes? 1 more minute. Okay. So just another thing that's on the horizon, we're looking at vitamin A, which is just a simple vitamin treatment. It's proven to reduce chronic lung disease in premature babies, but we've never given it because it requires an intramuscular injection 3 times a week. Nobody wants to do that into premature babies who've got virtually no muscle anyway. One of the things that my colleagues in Utah with their LAM model have discovered is that if you add retinoic acid to that vitamin A, you can give it orally and it works really, really well, much better than vitamin A by itself. So one of our next studies is going to be looking at using that in babies. So we're taking the LAM work now and putting that into babies, the VARA trial, and the goal with that, what we believe, we've also just recently shown that the VARA actually reverses some of the damage that the ventilator does to the breathing muscles. We think that we can also prevent some of the damage to the lungs and maybe improve outcomes for other parts of the body. Okay, so I think at that point I'm just going to leave that and move on to Adelaide. So, thank you.
Cool. Hello, my name's Adelaide. I'm one of the respiratory doctors over at PMH, and I'd like to thank you for asking me to come and talk tonight. It's a real pleasure to talk to you, particularly to our parents and all the parents who've participated in the research with their little babies. So, I'm going to be talking about flying in premature infants, talking about flying home from hospital or going on holidays. So obviously there's a lot to consider when you're flying with a small baby, and I'm only talking about their lungs and their breathing tonight, so not the other stuff. So unfortunately, I don't know how to make them stop crying on a plane, but hopefully we can make sure their oxygen levels are good. So why did we want to do this research? Well, we know that when you go in a plane, or you go at altitude above sea level where you normally are, the oxygen levels in the air actually drop. So when you're at sea level, which is where we are now, the air around you has about 21% oxygen in it. When you fly above sea level, the higher you go, the less oxygen there is in that air. And that's why when you go in an airplane, they have to pressurise it, because if you went up to maximum cabin altitude and there wasn't any pressure in your little cabin, you'd be breathing about 3 to 5% oxygen, which is obviously not enough for your body. So the further away you move from sea level, the higher you go, the less oxygen's in the air surrounding you. So when you're flying and you're at the maximum height that an airplane can fly at, generally there's about 15% oxygen in the air around you. This depends a little bit on the airplane you're in, how big it is, what the pressure is, but generally you get a drop from about 21% on sea level to 15% at maximum altitude. So why is this a problem? Well, when you breathe in less oxygen, there's less oxygen to go around to the tissues in your body. And for most people, this isn't a problem. We know that if you're a healthy person and you fly, the oxygen levels that we measure actually do decrease as you fly. But for most people, this doesn't really cause them any problems. It might contribute a little bit to jet lag and how people tend to feel a bit yuck when they fly because you aren't getting as much oxygen. But we know that when healthy people fly, if we measure their oxygen saturations, they can generally decrease to about 85 to 92%. And I'm sure those of you that have had a baby in the nursery know that we like to measure oxygen saturations. And where we'd be aiming for, depending on how old they are, is somewhere between maybe 92 to 96. So that's a pretty big drop even for a healthy person. And if your body has normally got lower oxygen levels, such as if a baby who's got chronic lung disease, when you fly, those oxygen levels can drop quite dramatically. So why does this happen to babies when they fly, or anyone who's got a lung problem? Particularly in babies, we know that when they're first born, especially when they're premature, their brains are not too good at controlling their breathing. So they'll often have big, long pauses in their breathing. They might have quite a variable speed at which they breathe at. And when you have lower oxygen levels, that becomes more exaggerated. One thing that premature babies tend to do is when their oxygen levels decrease, instead of breathing faster to get more air in, sometimes they actually slow down their breathing, and that can cause their oxygen levels to drop even further. When they're first born, particularly when they're premature, they've got very soft and bendy rib cages, and their rib cages don't tend to be very efficient at helping them breathe as well as they need to. So it's much harder for them to get air in. Also, their little breathing tubes, their airways are much smaller when they're first born, which means they're more narrow and it's harder for them to get enough air in. Also, the hemoglobin, which is a molecule that carries all the oxygen around your body, is a bit different in babies, particularly when they're premature, and it doesn't tend to carry the oxygen as well. So there's lots of reasons that babies have lower oxygen levels when they fly, particularly if they've got lung disease. So one of the problems for these poor babies, particularly if you're a premature baby or you've got chronic lung disease of prematurity, is this tends to be more of an issue for them, and they can have quite significant drops in their oxygen levels when they're flying. But it's not something you need to worry too much about because it's very easy for us to treat. It just means that you need oxygen when you're flying to bring those oxygen levels back up. So how long does this problem last for? We don't have a huge amount of data looking at this, but there have been some groups who looked at babies who were premature or babies who had chronic lung disease and how long they tended to have lower oxygen levels when they fly. There was one study that looked at babies who were premature, and they looked at them in the first few months of life, and about 35% of those babies needed oxygen when they flew. Some of the other studies have looked at babies who were premature or those who had chronic lung disease, but they don't actually look at babies while they're flying. They do a flight test, which I'm going to talk about in a second. But in these studies, some of the babies needed oxygen up to 81% in their first 12 months of life, and another group looked at children who were a bit older, and even some of the children up to 4 or 5 years of age who had chronic lung disease did need oxygen when they flew. So one of the reasons we're really interested in looking at this in WA is, as you guys know, we're a pretty big state. There's lots of places around WA where babies are born, but the only 2 places in all of WA that we can put babies on a ventilator is at King Edward Hospital or at Princess Margaret. So if you have a baby in Kununurra or in Bunbury and they're premature and they need help with their breathing, it's pretty common for them to need to come up to us here at PMH or King Eddies so they can be on a ventilator. Once these babies are a little bit better and they're breathing on their own and they don't need to be on a ventilator anymore, we like to get them back home as soon as we can, because often we have to separate mums and their babies, they're away from their family, and it's really inconvenient for families to have to travel here. So we like to get them back home as soon as we can. And a lot of these babies, particularly ones up north, will actually fly them home back to a hospital closer to them so they can have some more care at home. So we fly most of these babies home. One of the problems we're always faced with is, do we need to give these babies oxygen when they fly? Because we don't want them to fly and have their oxygen levels drop down. So one of the ways we can try and predict whether they're going to need any oxygen on the flight is by doing what's called a flight test. So if you remember back to the very beginning when I was saying when you're flying at the maximum height that you can fly at, it's equivalent to having about 15% oxygen in the air instead of 21. What we do is we put a little mask on the babies and we actually give them 15% oxygen instead of 21%. So that's like saying if they were flying at the highest altitude you could fly, this is how much oxygen they'd probably be having. So there's two ways of doing it. We can do it with the face mask, which is how we usually do it. You can also do it in this thing called a body box, but that's more easy to use if you're a bigger person. It's quite hard to put a baby in a big box like that and make sure they're safe. So what we do is we pop this little oxygen mask on, we give them 15% oxygen, and we monitor them for about 20 minutes to see what happens to their oxygen levels. And if their oxygen saturations drop to 85% or less for more than 2 minutes, we think that's a good sign that they need oxygen. Also, if their oxygen levels drop and they get quite distressed or they have symptoms which make us think that their oxygen levels are low, what we'll do is we'll start some oxygen into little prongs in their nose and work out how much they need to fly. So this is great because we thought, that's wonderful, our problem solved, we know how to tell what's going on. Unfortunately, this test is not very good, particularly in babies, at predicting what's going to actually happen. So one of the groups who works at Princess Margaret in King Edward studied a bunch of babies who were born in this state. There were 46 of them and they were all less than 35 weeks of age, and they'd all come from another centre around WA and been flown down. So what we wanted to do was fly them back. So we did this test that we used to do all the time to see how well these babies were going. And what we did was we actually monitored them the whole time they flew to see whether the test actually predicted what was going to happen or not. And unfortunately, the results were pretty disappointing. So 76% of these babies who passed the test and shouldn't have needed oxygen overall, but 11 of the babies failed the test and were supposed to need oxygen when they flew. And what we found that during the flight, 16 of the babies overall needed oxygen on the flight, but 3/4 of those babies had actually passed the test. So according to the test, they weren't supposed to need any oxygen. And interestingly, of the 11 babies who failed the test and were supposed to need oxygen, only 4 of them actually ended up needing oxygen on the flight. So it's not a very good test from what we saw. And some of the reasons we think the test isn't that great is because it's quite a short test. Obviously, no one's actually flying for 15 to 20 minutes, so the babies are on a plane for a lot longer. We don't consider when the babies are feeding and they're sleeping during the test. And we know from studies in adults that when people have a lung problem and they're eating or they're sleeping, their oxygen levels tend to drop down even more. So the fact that we're not actually... The fact that we're not actually looking at those times might be one of the reasons it's not very good. Also, the conditions are very different on the day to what happens when we do the test. We don't know what size the aircraft is going to be, which affects how high they can fly. We don't know what altitude they're actually going to fly at. The only thing that we did find was that if a baby had chronic lung disease of prematurity, or if they needed oxygen or CPAP while they were in the nursery, they were a bit more likely to need oxygen on the plane. So since we did that study and decided it's not a very good test, we've changed how we do things. So now at King Edward and Princess Margaret, all of the babies who are born less than 37 weeks who are transferred back home on a plane actually go with a nurse, and we have some oxygen with them. We monitor their oxygen saturations during the flight, and if it drops below 85 for 2 minutes, we start some oxygen, which is great, but it does mean we send a lot of babies on flights with nurses. So we were wondering if there was some better way we could predict who was going to need oxygen. So we went back and looked at quite a few years. Between January 2005 and May 2011, we went and looked at all of the babies who were flown back home. And you can see this is a little map here showing you all the destinations they flew to. So it was quite a wide range. I think we had 17 destinations that they were flown to. And we wanted to see if we could use things like what gestation were they when they were born, maybe how long were they on a ventilator. We looked at a whole bunch of different things to see if we could decide who was going to need oxygen during the flight. So there were 391 babies who were transferred between that time, and we looked at 311 of them that we had flight data. So we monitored every single one of them in flight to see what happened. This is a really busy, scary slide. Don't worry too much about it, but this is just showing you some of the things we looked at in this study. So we compared our two groups, the babies who ended up needing oxygen during the flight and those who didn't need oxygen during flight. Some of the things we looked for were what gestation were they when they were born, what was their birth weight, were they males, were they females, did they have a respiratory problem, did they need oxygen? So we looked at a really large number of things. And what did we find? We found that baby boys were more likely than baby girls to need oxygen in the flight, and we think one of the reasons for that might be that chronic lung disease is more common in boys than girls. Not surprisingly, we found babies who had a respiratory problem, such as chronic lung disease or hyaline membrane disease from being premature, were more likely to need oxygen than babies who didn't have a respiratory problem. Those that needed to be on a ventilator, who needed oxygen or needed oxygen for a longer time, were more likely to need oxygen in the flight. And interestingly, babies who were actually bigger at the time of the flight were more likely to need oxygen. We thought that was quite interesting because we sort of thought that the smaller babies would be a bit more fragile and maybe they'd need oxygen more. One of the reasons we think we might have seen this is that babies who had more severe lung disease probably stayed in hospital for longer, had a bit more time to fatten up and put on weight. And also, if we knew that they were sicker to start with, we'd probably want them to be very, very ready for a flight before they went. So we think that's why we might have seen that. And those who flew on a longer flight distance were more likely to need oxygen. So we decided to try and put some of these things together and see if we could make a little model. So if you were a boy and you needed oxygen and you needed to be on a ventilator, you were the ones who were going to need oxygen on the flight. Unfortunately, in our study, of the 168 babies who didn't have any of those risk factors, so no oxygen, no ventilation, no respiratory problems, 30% of them still needed oxygen during the flight, which was very surprising. And of all the babies overall who needed oxygen in the flight, almost half of them didn't have any of those risk factors. So what does this mean? Well, it obviously means we're looking at the wrong thing because we haven't found a good answer yet. We saw that almost 40% of our babies overall needed the oxygen during a flight, but there were a pretty big number of premature babies who required oxygen who didn't have a respiratory problem and who didn't actually need any oxygen or ventilation. So if we base our decisions just on those things, we're going to miss a lot of babies who are going to need oxygen on the flight who we wouldn't have thought would need it otherwise. Also, it's quite nice for parents to know that even if you have a premature baby who does have a respiratory problem and they did need oxygen and they did need it to be on a ventilator, it doesn't necessarily mean they're going to need oxygen during the flight. So we still recommend that in the first 3 to 6 months of life, when they are being transferred, all of the babies are flown with the nurse who can monitor them during the flight. And if you're flying your baby within the first 12 months of life, we will often do the flight test when they're a bit older to see if you might need oxygen. Particularly if they've got chronic lung disease of prematurity, they are still risk of needing flight oxygen if they're a little bit older. So in conclusion, there's obviously something going on that we haven't figured out yet. We've got some of the risk factors down, but we haven't figured out, obviously, some of the other important things which are causing some babies to need oxygen and some to not need oxygen. So at the moment, we're still pretty limited in predicting which babies are going to need help during the flight. So we're probably not measuring the right risk factors, but we don't really know what the other ones are. And if you guys have got any ideas, I'd love to hear them because we're obviously not looking for the right things. So we need to do far more research into this area. One of the other problems we have is we need to actually research, does this matter? can babies go on a flight and have oxygen saturations of 85 and not have any problems? We might be giving them oxygen when they don't really need it, but that's a very, very difficult thing for us to answer and thing for us to decide. So I'd just really like to thank you all for participating in our research. I'd particularly like to thank Graham and Andrew, who've been my supervisors and who've been absolutely wonderful. So thank you all very much.
Thanks, Adelaide. And so we're winding up now almost. So I'm now going to talk to you about the stuff that we found in school-aged children, and then we'll just have a bit of a question and answer session. If you do need to go, that's fine. Don't feel obliged to stay. I won't mind. So what have we been doing? So we've been focusing on school-aged children, and I talked to you earlier about the fact that children who are born less than 32 weeks seem to have more lung problems. So we've really focused on that group. And we've done 2 studies over the last few years. One of them was in children who were aged 4 to 7 years of age. And some of you may have been involved in the study. In fact, we have Liam here who was. And then also we did a second study in children who were 9 to 11. Now both of these studies were designed as separate studies, but because the second study came second, not surprisingly, what we tried to do was ask all of the kids that we'd seen in the first study, would they mind coming back again? And so because you guys are so great, actually 70% of you did. One of the advantages of that is that we can see not only what are the children like when they're 6 or when they're 10, but what are they like as they grow. And that's an important part of what we're doing is tracking how children grow over time, because it's really knowing how they grow that gives us our big answers. So what did we look at? So we looked at a whole range of lung function tests, because that's what we do and we think it's fun. We asked about breathing problems and symptoms. When they were older, we got them to run on a treadmill until they couldn't run any longer. And we've got, particularly Chris, for those of you who have been over to the laboratory and met Chris, he's very good at making kids run until they cannot run any longer. He's a bit nasty that way. And then we also did a chest CT scan. So that's basically a fancy X-ray so we can have a look at what the lungs are like. And then really just to see how much does being born preterm impact on the lung in later life. So after Jane and Andrew and Adelaide have finished with them and they're at school and playing football and netball and that type of stuff. So what did we find? So we had a number of children. So this is when they were 4 to 7. So this is part of Maureen thesis research study, and those of you who've been over to the respiratory laboratory at PMH will have met Maureen before. But what we found is, so just to orientate you, this 2 and -2 is really anything inside of there is normal. So we know that an individual, there's an average height. So the average height of men in the Netherlands, for example, is 185 centimetres tall. So that's my height because they're quite tall. And so an average person, their height would be equal, on this scale, would be 0 in the middle. But there's also a normal range of height. So some people are shorter and some people are taller, but they're not really tall or really short. They're just still normal. And so they can be anywhere in here. And what we found is that if you were born preterm but you didn't have neonatal lung problems, that you tended to be lower than those children who were born term but still inside of the normal range. And that if you had bronchopulmonary dysplasia or you had neonatal lung problems, you were lower again, but still in the normal range. So we see that the lung function was still normal, but it was just a little bit lower than those who had been born at 40 weeks or term. One thing we did find, which we thought was a little bit surprising, was that a lot of children reported that they were having some form of symptoms on when they were exercising, so cough or wheeze or chest tightness. And this hadn't really been reported before. And that was around 30 to 40% of the kids that we saw, which is quite a lot. It would be less than 5% in the normal population. And what we found is that those children who said that they had some kind of symptoms with exercise tended to have worse lung function. Now, we don't know which is the chicken and which is the egg. Do they have low lung function because they've got symptoms, or do they have symptoms because they have low lung function? And that's something we're still trying to work out. but it starts to point at a group that maybe we need to be looking at a little bit more carefully and talking to parents about whether their children are getting these symptoms, and if they are, trying to work out how we can help that particular group, because maybe they're more at risk. And because what we really want is for kids to be able to go and play footy or netball or rugby or have a swim and do all of the things that kids do without having to worry about, but what if I can't breathe, or what if my chest's tight, and opting out of physical activity or climbing a tree or going on a bike ride. So what about when we saw them again at 9 to 10 years of age? So what we saw is that if we compare them to just a general Perth population, so for example, about 16% of children report some form of wheeze in the last year. If you went out to any school and got 100 kids in a row, 16 would say that they'd had some breathing problems, some wheeze. And that was much higher in preterm children, either those who hadn't or did have neonatal lung problems. But there wasn't any real difference between the groups. But once again, you can see that we had quite a lot that said that they had some kind of symptoms with exercise. And when we looked at the lung function in those groups, what we can see is that it really didn't matter, and these are all just different ways of measuring lung function because we like to do it in as many ways as we can. What we found is that those who had some kind of breathing problems when they were exercising vigorously, that their lung function tended to be worse. So this wasn't just a problem of when they were little, they weren't really growing out of it, it was still there when they were 9 or 10 years of age. And so one of the things that we're hoping to do next is to try to tease this out a little bit more so that we can be giving families better advice on maybe how to manage this. One of the other things we did, so you remember I talked to you earlier about, this is the lung tissues are this little honeycomb sponge, and that if you're born early that this sort of grows differently. With our x-rays, we found that most people who were born preterm, so 95% of them, their chest CT was different to what we would expect in healthy term-born children. We don't know what that means. It probably just means that their lungs are a little bit different because when they were born preterm, they've grown up a little bit differently. But this is something that we're trying to explore to see, does it really make a difference? Or if it doesn't make much of a difference, is there a point at which it begins to make a difference? So once again, we can sort of say, okay, we know that most of these preterm children, their lungs will be a little bit different, but that's okay. But there's this small group where maybe that's not okay, and we need to keep an eye on them a little bit closely. So what do we want to do next? So we really want to look at how symptoms and lung function change across childhood. So in those children that we saw at 4 and 5 and 6, and we saw again at 10 and 11, we want to look at how their lungs grew, whether their symptoms got better or worse, or did they disappear altogether, and try to work out what are the things that might be driving those changes, because that'll enable us to start a conversation with Jane and Andrew and Adelaide again to sort of say, well, this is what we're seeing, and you guys see that as well, and how can we maybe tweak what you're doing so that we don't see this anymore? So we're still in a job, Jane. We want to look at whether being born preterm changes exercise capacity. So I told you that we ran lots of people on an exercise, and while I haven't shown you that today, what we found is that those children who are born preterm don't tend to be able to exercise to the same level as term-born children, but it's still in the normal range. But some of them had more problems than others, but we don't understand what that is, and so that's something that we're looking at. And one of the things that we're very interested in looking at, and we hope to do next year if Tony Abbott doesn't cut the budget too much, is to look at whether physical activity that preterm children are doing is influencing their symptoms, or is it the other way around, or is it something altogether? So in those children who say that they have symptoms on exercise, what's causing that? And are there ways that maybe that we can get around it? Are they having symptoms with exercise because they're not doing as much physical activity, which we know is very good and can reduce symptoms because their lungs are not quite the same? Or is there exercise maybe they could do that means that they could get around that? So that's something we're hoping to do next. So I guess just to summarise all of the things that we've talked about tonight, being born preterm does lead to changes in lung health in childhood, but it's not all bad. A lot of it's still in the normal range. And really what we're trying to tease out is which of the children should we be looking at the most, but also which families we can say, we think everything's going to be all right, so you don't have to worry too much. We want to know, what we have found is that if you're born with neonatal lung disease, so BPD, it doesn't lead to more symptoms than if you're born preterm and you haven't had problems, haven't needed the ventilation or the oxygen in the neonatal intensive care unit. I think that's quite an important message that we can give to our families. That being born preterm does change the way the lungs grow, but we don't really understand how what the long-term impact of that is yet. You can't do this work without help of lots of people, and we're really lucky that we've got, both at Telethon Kids and PMH and King Eddie's, we've got a really engaged and dedicated team of researchers and clinicians who have made doing this type of work a core part of what they've done. And we can't do that without funding, and we're thankful to those people who do help us fund this research. And so now we're going to have just a sort of a question and answer panel session. So I'm going to get Jane and Andrew and Adelaide to come up and sit in the hot seats. So if anyone has any questions or comments for any of us, if you'd like to throw your hand in the air. So one down the back, yeah.
Are you going to be doing any research into children who get outdoors more and their lung function and immunity and I guess things like asthma and that improving because they have been outside more?
Yes. And I guess the way we fund all of this research is that we write up a big proposal and we send it off to Canberra, and a whole heap of other people who do research look at it and decide whether they'd like it to be funded or not. So we currently have a proposal like that at the moment, and where we're starting initially is to look at a really big group of children who've been born preterm and to measure how much activity they're doing. So we're going to, if we get funded, we're going to put little accelerometers on their hip, which basically, you can get iPhone apps that do the same thing. It tells us whether you're sitting still, whether you're on the PlayStation, whether you've gone out for a bike ride, and how often you do that. And then we're going to look at what their lung function is like and what their symptoms are like to see whether those children who do lots of activity have less symptoms and breathing problems. And then what we hope to do is follow them over time and see whether those who increase their physical activity get better over time. So that is something we hope to do. The first study will probably take us around 3 or 4 years to do because we think slowly sometimes.
I was kind of referencing more to them getting into dirt, like as in like these preterm babies, having a preterm baby who was born 31 weeks, 4 days in a sterile environment, and that sort of continued at home, you're so careful. And then, a year and a half just being sick for about 8 months with asthma and all this sort of thing developing. And then finally in summer going, okay, let's go outdoors. And then as this winter is approaching, he's so much better. He's hardly needed Ventolin, all those sort of things. So it's that more so to do with the immune system and the response and being outdoors and getting dirty and all those things kids are meant to do.
I guess that's not something we're specifically looking at as part of this proposal, but the relationship between the asthma symptoms and prematurity is really tricky and really difficult to work out what's going on. Because we know if we look at even in our data as well, there was a huge number of kids who are getting asthma medications and far more that actually should have asthma. When we look at some of the other things that go with asthma, like hay fever, for example, there's no more hay fever, there's no more eczema. These kids aren't more allergic, but they're getting more asthma symptoms. So some of that may be the changes in lung development itself. Some of it may be that it's just a function of the size of the airways or something different about the muscle, or it may be that there actually is ongoing inflammation in the kids who've had a history of prematurity that responds to asthma medications. The immune development stuff is tricky as well, and we really don't know with asthma development. There are some theories. There's a thing called the hygiene hypothesis, where people have thought that if you grow up in a very sterile and not exposed to bugs environment, you're going to start finding something for your immune system to do, so your immune system's effectively going to attack itself, attack you, and you're going to end up with diseases like asthma. And the best evidence in some ways for that is if you grow up in a farm on Germany and you drink milk effectively direct from a cow, you don't get asthma. But other than that, we haven't really found a way of preventing asthma by exposing people to bugs. People are starting to look, and there will be trials actually exposing people to mixtures of stuff from bacteria. So people look and say, what if we give probiotics? Does that make a difference? But if you give a probiotic, you give one bug, and one bug probably doesn't make a huge difference. But if you give extracts of 50 different bugs that don't cause disease but might actually get the immune system interested, then it might actually have something else to do and not cause some of these diseases.
I might just add to that. I mean, what you're describing is actually very normal behaviour for a lot of babies, and anyone even with a healthy term infant who sends their child to childcare knows that the first year or two is just a nightmare. I can't remember how often I was at work versus at home looking after a child that was sick. But once got them through that first 2 years and they've done all that nasty illness stuff, they then can often be healthy for the next 15 years and never miss a day of school. Whereas, a child that's kept in a continued protected environment gets all those bugs much later and then often more protracted sense. So what you're describing in many senses is not necessarily something that's particular to being preterm. I'll just mention on the probiotics, it's actually something we're now giving routinely to premature babies, and it is one of the big advances that we've had in neonatology that's making these babies better, because giving the probiotics means they're not getting sick in the NICU, they're not getting nasty gut disease, and then they're not getting the other infections quite as much. And that's important for their lungs as well, because if they're not getting sick, then they keep breathing. If they get sick, they forget to breathe. And when they forget to breathe, we put them on the ventilator, and then that damages their lungs. So the whole thing's just interlinked and intertwined, and a big round circle.
Hi, I'm sure this is a bit of a tough question to answer, and I'd be surprised if you can give me an answer to it, but I'll ask anyway. Rory here is an ex-25 weeker. He was ventilated for almost all 17 weeks that he was there. He's now 4 months corrected and hasn't had a sniffle, a bug, hasn't had anything. My question, and he has chronic lung as well, my question to you is, knowing what you know now up to school-age children and where they've come from, should I be expecting a kink in the road, or is it something we can't tell till, the first cold kicks in and we see what happens from there? Winter's coming, isn't it? I know it's a tough question.
So those of you with older school-aged children, there's always a kink in the road. I do expect it. Yeah. Look, and I think Rory's a great example. We have some children who are 34 weeks who seem to have no problems but then have lots of problems later on, and we have other kids like Rory who are 25, lots of problems in the NICU, and then when Jane's finished with them, although his manners are not very good, when they get out, they're fine. And really, when you saw the data that we had, you would have seen that, we had the box and then there was those little lines, and it showed that even those children who had chronic lung disease, some of them had lung function that was almost better than normal. So there is a big range, and there's a continuum, and all of the things that we've talked about tonight are really an average of a group of children, and they may not reflect individuals in there. So it's really difficult to say whether one individual is likely to have problems. The fact that he's having such a great start is fantastic, and I would just assume that it's going to keep being good, because I'm a silver lining kind of guy. I think there was a question up the back, Lauren. Yeah.
I've got two questions, if that's okay. The first one is, our son's 2, and I'm just wondering, he is very active, but from the future, I guess, what type of levels of sport do you recommend he should be doing, or is there any specific physical activity that you would recommend to help with his lung function?
So I think generally there's guidelines in Australia for how much physical activity children should be doing, and I think it's now at least an hour every day. Do an hour every day. Exercise, physical activity is good for everybody. It doesn't just help help lungs. It's great for your immune system. It keeps your weight down. It's good for hand-eye coordination. It makes you happier. It reduces mental health problems. You get to go to some great parks, maybe kick a goal, shoot a netball, get a hole in one. The more the better, really. And I don't think there's any real type that's better or worse than anything else.
like, you know how people when I was a child, like, if you have asthma, then you should do swimming or that sort of thing.
Yeah.
There's not,
I might just pop in there and just let you know, we actually have some world champions in our ex-preterm babies. Some of them have gone Paralympics, for example, come home, broken world records. There is nothing you can't do, and no disability should stop any child from getting out there and doing some exercise of some sort.
To answer your... I'd say as much as possible of whatever they like to do. The more exercise, the better. And
Thank you. And my other question was for Adelaide about your flight work. Have you looked at full-term babies and what their capacity is on the flight as well to see a difference?
that's a very good question. We have done some with term babies, not many, but we do try and grab normal term babies when we can, when we know they're flying. And probably the best person to answer that is Graham.
Some of the stuff that Adelaide showed you where we did the flight test on the ground and then threw them up in the air and saw what happened. We also did that in term babies. And what we found is that even in babies that were born term, some of them, their oxygen levels did drop below 85%, which really which has sort of led to one of our conclusions is, does being below 85 really matter? So for us, it's a safety switch. If it drops below 85, we all start getting a bit agitated. It may not actually matter for the baby. So we're really trying to work out now, how can we answer that question? It's a difficult study to do safely. And, the safety of children and babies who help us with this research is paramount for us. So we're still trying to work out how we can answer that question so that we can answer your question, but in a safe way. So maybe in a year or two you can come back and we can tell you. I think there's a question here and one up the back.
Hi, I've got identical twins that were born at 29 and 6 weeks. Just giving you a picture. I just wondered, with the preterm chronic lung disease, is it always classed as that, or do they get to a certain age where it's just classed as something else, or it becomes something else, or they grow out of it? I know you don't have a huge amount of research because those people are the same age as me now, but I just wondered what your thoughts were on that.
It doesn't really have a name. And it makes it silly calling it chronic lung disease of infancy when you're 21 years old, for example. So I've been involved in some research at Royal Perth, and we followed up young adults up to about the age of 25, and some of them did have significant lung problems, but we still don't really have a name for it, and nothing's really caught on. But I guess what's clear is that we do need to think beyond the neonatal period and beyond infancy, and we need to keep thinking. So the most difficult group for us is we do see a group of kids at 10 or 11 years of age who can measure their lung function as being low, but they're not reporting a lot of symptoms, apart from perhaps those symptoms with exercise. So what should happen with those kids is really uncertain, and whether they've got recovering disease or whether there's still something active going on in their lungs, we still don't really know. So I think we really need to pay a lot of attention to those kids through those school age years, and just to try and work out what's going on. Are there things we can do? And we're looking at physical activity as one of the, well, you might say relatively simple things, but that we can intervene to see if that changes outcomes. But there may be other things as well we can look at that might change outcomes as well, like asthma medications, for example. Does that make a difference? We know that a large number of kids are getting them. We know that if we measure response to the asthma medications, that lots of the kids respond. So should they be on those sorts of medications even though they don't have symptoms? So there's still lots of unknowns around that.
Thank you. And a question to Graham. You've mentioned about, it seems to be that the trends to 9 and 11, that they're sort of pretty much in the same ballpark. Is there studies around the world showing at ages beyond that? Does it track in pretty much the same way? So other studies?
Yeah, so I mean, there are a lot of studies that have followed babies that have born preterm, as Andrew mentioned, up into adult life as well. But you'll remember one of the things I talked about earlier is that, you know, how what's happened in the neonatal intensive care has changed so much. So one of the things that we're trying to work out is whether the studies that have reported that stuff in adults who are now 25 or 30, for example, will that still apply to those who are going to be 25 in the next 5 or 10 years? So that's one of the reasons why we're doing it. There's a group in Victoria that do a lot of work following preterm children up, and they've done some very big studies in 18-year-olds, so at the end of their adolescence, if you like, and found similar things, that you seem to show that children who were born preterm who had no neonatal lung disease, their lung function tends to be a little bit lower, but not much. And those who had neonatal lung problems tend to be a little bit lower again, but they're still in that general band of normal. We do see some individuals whose lung function is below normal. However, we would see that in 21-year-old who had moderate asthma, for example. So then it's hard to tease out their lung problems because they were born preterm or just because they've been around 21 years and maybe they do have asthma, because I guess there is a risk of having asthma as a child, and that risk isn't really different. It certainly isn't lower if you're born preterm. So it may be that being born preterm has nothing to do with those. But there are studies that are doing that. And one of the things we're trying to work out is how much of that information can we still apply? Because if Jane and her colleagues keep getting better at what they're doing, then we have moving goalposts. And really what we're trying to do is pin those goalposts down as quickly as they can before they move again. I think there's lots of questions.
Thank you. A question for Adelaide. I was just wondering, it's not really on preterm kids, but perhaps if a child had CF or another serious lung condition, do they need to be concerned if they're going on holidays and flying?
That's a very good question. So there have been a few studies in school-aged children with cystic fibrosis, and the two big studies showed that they did have lower oxygen levels when they flew, as we would expect, but the vast majority of them did not have any symptoms. So the recommendations are currently, for children with CF at least, that the decision to do a flight test should be based on what their lung function is and the number of infections they've had recently. So there are guidelines about who needs to be tested and who doesn't. Generally, if someone's got normal lung function with CF, they shouldn't need to have a test before they fly. There's also some guidelines for things like asthma, and there is no evidence that any child with asthma needs to have a flight test. The only reason we'd want to avoid them flying is if they've just had an exacerbation and they're sick, in which case they shouldn't be flying anyway, and that's more of a safety issue, that if they get sick on board, there's not much you can do. So there are guidelines for different medical conditions. The best studied one would be cystic fibrosis.
So I'd just like to say congratulations. I'm a mother of twins that were born 28 weeks, but 23 years ago, so they're called new Prem on your thing up there, and the difference is obviously amazing, and they've got lung disease, but they also are new graduates of university, so they do survive. But I'd like to congratulate Adelaide. They were in hospital for 14 weeks. I was put on a plane to go back to the country with 2 babies, and I've never been so scared in my life, because suddenly I had no support, no apnea mat, no oxygen. And I mean, they're okay, they survived, and I did too. But it's fantastic research, thank you.
Thank you very much.
I've got a little boy who's just turned 2. He's a CLD baby, but he was severe IEGR. And I find that every time that we end up having to come in to PMH, there's a lot of discussion about the difference between doing the CT or doing a normal X-ray. Is there a way of getting your data out there so that the GPs can order these CTs to see how much damage is actually happening? Because, I mean, my child's had like 20 X-rays because they just see how bad his lungs are. So
a CT scan does give you a lot more information, but it doesn't necessarily change what you're going to do at the time. And it can be useful in some situations where kids' lung disease isn't playing out as we might expect it to. But for many kids with chronic lung disease, we can kind of predict their course, and we know that for some kids, every time they get a virus, they are going to get sicker. And often what we try to do when we're looking after those kids is to put a big sticker on the note saying, don't do an X-ray. Because it doesn't actually change what you do sometimes. Now, there may be very good reasons to do an X-ray in certain situations if people are concerned about pneumonia, for example, but often it's important for us, we sort of think, well, we try not to do them as often. The CT scan, as I say, can give you some useful information, but we're not at a point yet where we can say the CT scan at the age of 2 means this at the age of 10 or the age of 12 or anything like that. So it's very much a small percentage of kids with chronic lung disease who should be getting a CT scan at the moment, I think.
Last question. Lucky last.
Hi, sorry. You touched on it briefly about the asthma medications. My daughter, she's nearly 2, she's the next 25 weeker, and every time she gets sick, depending on the GP you see or the specialist you see, they're always, not conflicting, but they've all got different opinions on asthma medications. And I don't know whether you've tried, but getting an asthma puffer on a 2-year-old is just horrible. So I don't know, is it more distressing trying to put it on there than it's actually going to be beneficial for them? What are your opinions?
Look, there's not a lot of evidence either way as to say what we should actually be doing, and there's a huge variation in practice. If you go to the US, nearly all kids with chronic lung disease routinely get put on asthma medications. And here it tends to be much, much more sparing. If you've got someone who's wheezing who responds to the asthma medication, then the simple thing is you give the medication. But there's no point giving it if it doesn't make them better. And that's something that sometimes it's only a pattern over time that you can see. Sometimes we see kids who have recurrent illnesses where they definitely respond to Ventolin. We're much more likely to put those kids on an asthma preventer as well to see if it makes a difference. Now, there's lots of things that will make a difference there. If you've got 3 other kids who've all got asthma who weren't Prem and you've got asthma yourself, then obviously it's more likely we're treating asthma. But if not, then it's really an individual thing, and we're still looking for more evidence there. We've got another proposal in currently for a study looking at kids who with a history of chronic lung disease who respond to Ventolin to see whether putting them on an asthma preventer actually changes their lung function over time and changes their symptoms over time as well. So it's something that we're looking into, but at the moment we don't have really good evidence of it, and to say you've just got to take it on a case-by-case basis at the moment.
Okay, so I think we're going to wrap it up there. I'd like to thank you all for coming. I'd particularly like to thank you if at some point you've crossed our paths by being involved in your research. I'd like to really thank you very much. None of what we would do would be possible without you, and hopefully we will see you all soon. Thank you very much for coming.